as the equine pars intermediate dysfunction, or in other words, the hyperadrenocortacism, pituitary hyperadrenocortacism in the equine. I'll repeat a few things so that we're on the same wavelength and everything. And I had to ask your classmates what we left off with, because when I'm doing endocrinology the first year, the same time I do it with you all, I can't remember which one's which as far as where I am, because we're the same subject on it, okay? All right, so remember that the equine pars intermediate dysfunction, or PPID, is the manifestation of pituitary-dependent hyperadrenocortacism in the horse. And the reason they call it that, because what is the intermediate as far as the pituitary is concerned? What is it? You know, you remember the adenohypophysis has three parts. The pars distalis, the infundibulum, and the intermedius. And the intermedius is very close to the neurohypophysis, what's between the neurohypophysis and the pars distalis. And it's also very close to the infundibular stalk. So the problem in the equine, that's generally where you get most of these things are caused by tumors. And that's generally where you get the tumor, and so you can see it can damage the neurohypophysis, it can go up and cause problems as far as the hypothalamus and everything. So that's one reason we get a lot more diverse clinical signs as far as the horse is concerned. And basically it can result, if it's a big enough tumor, it can result in destruction of the pars nervosa. And what hormones is that going to interfere with? ADH? And oxytocin. You might be able to do without the oxytocin unless it's a broodmare or something, but you can't do without the ADH, okay? And basically a lot of the things, as we say, the sweating and the inability to shed the hair and all that stuff is due to its proximity to the hypothalamus, where you have those various regulatory centers that can interfere with those, and that's one reason we see it. And those tumors can get so big that they compress the hypothalamus. And that messes up a lot of osmorecepting, temperature receptors, and everything else. So as far as equine pituitary-dependent hyperadrenocorticism, it is very active, and some of the signs are associated with ACTH excessive, but other signs are associated with just total mess up of the surrounding tissue. Okay, one of the things you'll see is a long hair coat that fails to shred. What's the term for that? What's this long hair coat called? Well, we're using hirsutism. It's hypertrichosis, but what sounds better, hypertrichosis or hirsutism? Okay, and basically it's the clinical sign you most commonly see associated with equine Cushing's disease. It's about 85% of the reported incidents have this, which is very high. And you can see what they look like in here, and this can be in the middle of a hot summer, and they'll still look like this, okay? And this is not, you also see it in Shetland ponies, and they ain't shaggy anyway, but they're even more shaggy than what they normally are to have this condition. Okay. Other signs include basically, you get the alopecia in your canine and your equine stuff, your feline stuff. You also can get some patchy alopecia as far as the horse is concerned. It's generally going to be around the abdominal cavity where they rub and this type of thing. But they don't have that nice, pattern that you'll see in the dog as far as this is concerned. They're kind of in between that patchy thing you see in the cat and the nice bilateral you see in the dog. Okay. And one of the things you also see in the jugular furrows areas, you can get hairs as long as 6 inches and stuff in those jugular furrows and stuff when you're doing that. And that can give you a problem when you're trying to take blood from the animal that comes into your clinic. You usually will have to end up shaving an area because it gets in your way. Okay. They will get weight loss, muscle atrophy, and a horse is supposed to have a nice smooth top line, they lose that. And basically, you can see, you think those horses are going to perform very well out in the field or anything like that? No. Now, PUPD commonly occurs, and that's going to be in conjunction with the destruction of the pars nervosa with interference as far as ADH is concerned. Also, it's going to increase your glomerular filtration rate, and it's going to interfere with the ADH receptors. If you don't destroy the pars nervosa and you still have ADH, it will interfere with those receptors in the tubules. It blocks them, and so that's why you get severe PUPD with it. Okay, and also, what's the glucocorticoid blood glucose level? Increase it, and that's going. If it exceeds the renal threshold, it's going out in the urine, right? And what kind of thing will glucose cause? Why do you get PUPD with diabetes mellitus?
You're trying to dilute the sugar.
Well, not so much as that glucose is an osmotic thing. So when it goes out, it pulls the water with it. And it will do it so rapidly that the tubules don't have time to be absorbed. And so that in conjunction, that will occur with this, in conjunction with blocking the ADH receptors and possibly destroying the source of ADH. So you get some severe PUPD with these animals. They will have a ravenous appetite because remember they can't utilize the glucose. And what's the satiety center telling them? Gotta have more glucose. And so the animal's going to have gluconeogenesis, is also going to try to increase glucose intake and all this type of thing. And you'll get, this ravenous appetite is not going to really help much because they can't really utilize the stuff that they get. But they will eat down. There's been cases where horses have actually eaten their whole stall, boars in their stall when they have this condition. Not just from, the cribbing, but just plain eating as far as this is concerned. And they can get somnolence. I mean, we have a lot of that problem, don't we? Especially before exams and stuff. But it's very pronounced as far as these animals are concerned. Get intermittent hyperpyrexia. In other words, the hyperhidrosis can cause that because if you're insulating the skin, what's that going to do to get rid of sweat and stuff? Also, it can interfere again with the hypothalamic heat regulatory centers, and so you can cause those types of problems. And since it's a lot of steroids, what does that make them more susceptible to? Infections. And one of the major problems that we see as far as the horses are pulmonary infections. And very often that's the thing they come into the clinic for because they're not breathing very well. Even though they look like some of those pictures, they don't worry about them until they can't breathe very well. And then they bring them in. And main culprits are Nocardia species. You can see over there on the far side. Remember, Nocardia is acid-fast positive. It's not acid-fast positive with the very discriminatory thing for mycoplasma, but it is for the routine acid-fast stain. We also see Coccidioides immitis in the center there, and Aspergillus species over on this side over here. These are, now that doesn't mean you can't get other ones, but these are some of the more common ones, and these are also some of the hardest ones to treat as far as any animal is concerned. You get a chronic insidious onset of laminitis, and again, they may be breathing heavy and everything, but then they start to not be able to walk. Now says, "Oh, I got to take this animal in. It's got acute problems here." Yeah, I mean, especially if it's y'all heard of Sunday morning owners and stuff. That the only time they ever see their animals is on Sundays, and that's one of the problems we have with some of these animals. But this insidious laminitis is usually the most significant complication you'll see with PPID in horses. About 50% of them. And as far as this is, since they have a tendency toward developing secondary infections down there, including skin infections, get sole abscesses. Well, if you look at these feet, does that look very good down there? And one of the problems with this is one of the hardest things to treat as far as this condition is concerned. And very often it's irreversible. Okay? But you can also get conjunctivitis with these problems. You can get sinusitis, gingivitis, everything. You get infections in everything with this problem. Okay, you can get delayed wound healing. Why do you get delayed wound healing with hyperadrenocortacism?
Decrease immune response.
To heal a wound, you have to form a scar, right? What do you need to make a scar? Connective tissue. What do steroids do to connective tissue production? They inhibit it. Okay, and when you do that, why do you think you get the abdomen? Not just because of the muscles, but also because of the connective tissue weakening in there. Also, can you get ruptured blood vessels and things? That's also one of the problems, is because you can get very weak vessel walls, and you can get aneurysms, thrombosis, and everything else going on with this stuff. Okay. Of course, you get infertility or a lack of the estrous cycle. And you get abnormal mammary gland development. As far as I'm concerned, these are some of the minor problems compared to all the other stuff they see. But I'm a female, that might be because I feel that way, okay? All right? Now, as far as clinical pathology, CBC, what's strange, frequently they have a normal CBC. When it is altered, the most consistent thing is your stress triad. And you all remember what that is, right? What's a stress triad? You got leukocytosis characterized by mature neutrophilia, a lymphopenia, and a eosinopenia. Very good. Okay, so that's what you want to see with that. Okay, and as far as other findings that you can see will depend upon whatever there's secondary infections going on, whatever they are, this type of thing. Now, again, you may not see a really good inflammatory response to these infectious agents because what's the steroids do to the inflammatory response? They can inhibit it, okay? As far as serum chemistry is concerned, it's going to depend upon several things because, again, you know, when you have hyperadrenocortacism, the body can't use the glucose, right? But what does the body try to do? Make more glucose. What's it used to make more glucose? The lipids and amino acids, weakens muscles, immobilization of fat and everything. And so what can happen to the liver in those instances? You get fatty liver, this type of thing. So depending upon what degree that is at, will depend on whether you see any clinical chemistry associated with that. Okay? Now, as far as the, you're going to see hyperglycemia. That's the most consistent thing you're going to see. If you do have liver problems, you're going to see increase in AST, ALT, alkaline phosphatase in there, GGT. Abnormal bile acids we talked about. Y'all remember the bile acids we talked about the other day? I probably don't, but anyway, but you can see those, okay? But they're made by the liver. Also, hypercholesterolemia and hyperlipidemia present. Basically, when you see them, that's one of the ways you determine the prognosis. If it's gotten to the point where you have hyperlipidemia and hypercholesterolemia along with hyperglycemia, prognosis is great. The horse will take longer than the cat. You can look at them funny and they develop acidosis, right? Horse takes a longer time. So by the time the horse is showing it, what do you think the condition of that animal is? Very bad. Okay? Baseline of resting plasma T4, T3 are normal. Why do we want about the T4, T3? Remember, your steroid hormones can cause euthyroidism, right? And that will give you these low levels, but it doesn't seem to affect the horse as much as it does other species. But again, that's not going to make much difference if they look like that, right? See pictures of them. As far as diagnosis, well, there are a variety of diagnostic tests available for PPID as far as equine is concerned. In equine practice, poor test sensitivity makes it a lot harder for the veterinarians to diagnose this patients because we get a lot of false negative results. All right, the plasma cortisol concentration can be measured, but it's going to be so variable. Is any baseline hormone level very good to diagnose an endocrine disorder? No. And so it's not that great. Now, in 2011, they did have a group of people working with the American College of Veterinary Internal Medicine that gave up a diagnostic workup algorithm, PPID, that consists of 2 tiers. And they said the use of tier 1 test was the best first step in evaluating a horse for PPID. Here is tier 1 endogenous ACTH levels. And what's the difference between endogenous and exogenous? Endogenous is what's in the body. And what's causing the hyperadrenocorticism in these instances? Excess secretion of ACTH, right? And so basically a single blood sample may be all that you need, but because there is some fluctuation in the hormone, it may not give you a clear-cut view because you might just hit it when it's low normal, when it's just about not quite low normal, but in the middle there because it's doing this, and you say, oh, this animal's fine. Now, can you look at those animals and say that they're fine? No. But generally, if you do get that, you need to take multiple samples and measure them. Now, when's a horse most active? Day or night? In the day. So basically start out early in the morning and then maybe 4 hours later take another sample, that type of thing. The high-dose dexamethasone suppression test, y'all remember that from the other day? What will high-dose dexamethasone do in a normal animal? Cut the blood cortisol levels down to about 1.25 micromoles. What about if you have an animal that has a pituitary tumor? In a dog, they may be responsive. They'll cut it in below 50%. But the one up here in the horse and intermedius, it's not going to do anything. So the high dose dex contain, if you don't get a drop in cortisol with a high dose dex, then that definitely tells you you don't have a normal pituitary up there. Okay? Now, it's basically, it used to be the gold standard. It's still used in small animals, but again, because that tumor is in the intermedius, it doesn't respond. And that's why we start using mainly the endogenous ACTH to give us our better information. All right, as far as tier 2 is concerned, you use a thyrotropin releasing hormone stimulation. All right, so which means, why use TRH? Well, the pituitary adenoma cells in the horse lose receptor specificity for the hypothalamic releasing hormone for TRH. So basically, in a normal animal, a normal horse, you give TRH that stimulates and affects the ACTH, and basically you'll get an increase in that. If you've got a tumor up there, it's not going to give you any more increase than it already is when you give that. Okay, so y'all can read 3 of these. Most of the veterinarians in the field, this is a little expensive to do these 2 tiers, but if you can get a good diagnosis with just looking at your ACTH levels and things, that's generally enough. But if you get those animals that you don't read the book, then you have to do this more extensive evaluation of them. Okay? Now, as far as treatment, if it's a tumor up there in the pars intermedius, do you think you're going to be able to do surgery very easily? Because, one of the approaches in animals for tumors in there is to go through the, they go through the nasal palate, go up in the heart palate, go up in there. But that can be extremely difficult where the horse's head is made. And the horse's head is hard as rock. Okay, that's literally. And so it's hard to get access to it. Basically, the most effective ways is to manage the PPID. In other words, proper diet, administration of an oral medication that will hopefully, what it is, you're giving an oral medication that will prevent the adrenal gland from responding to the ACTH. And that's one of the main things we use for them. But you want to use a low sugar, low starch diet. You want to give adequate vitamins, minerals, and proteins. Limit grain, because grain can cause a lot of increase in glucose and stuff. Limit pasture excess, because you can get that grass and stuff. It can basically have a very high carbohydrate content in it, and that type of thing. You need to basically maintain a normal bottle weight as much as possible. And just dietary management's the main way you can do it, because there's not very much access as far as getting this thing out. Okay? Now, as far as drug therapy, it is a medication of choice, is a dopamine agonist that's called pergolide mexylate or Persind, and it's basically acts like dopamine. Remember, dopamine is one of the things that big mama, that molecule of stuff comes from. It inhibits cleavage of that. And so it can basically decrease the amount of big mama available, and it will decrease the cleavage of that molecule into ACTH. Now, it's variable as far as how good it is. It has been approved by the FDA. It's a pill form. You put them, dissolve it, 1 milligram tablet in a very small amount of water, and you administer it with a syringe, or you can stuff it in a treat like a carrot or a piece of apple for the horse. But if the horse is not eating, that's not going to work, so you're going to have to use the syringe. It's a broad dosage range. You usually start at the lowest dose. If you don't get any response, then you go up by multiples of 2. And then hopefully you'll get a dose where the symptoms start to subside. You're going to keep them on that for a little while, and then hopefully you can bring it back down a little bit. This stuff gets pretty expensive after a while. Okay? Another drug that works is cycloheptadine, and it works at the pituitary gland on the brain. It's a serotonin antagonist, so it basically does the same thing as pergolide, but it might not be as effective at improving the clinical signs as the pergolide is. So we don't use it as much, but sometimes the pergolide won't work, and so you've got to go with this one. And it's been used with success by a lot of practitioners and owners. when they, again, you may have to use it in combination with pyrrolite. But the more combinations you get, again, the more expensive it can be. All the combination of two drugs is more expensive, but again, it may be more effective to use. Okay, and now that most people, what if it's just their daughter's horse? They gonna pay for it? Yeah, this is this baby's horse, right? So they'll do that. Now, what if you're probably talking about a equine farm that maybe rents horses out for riding and stuff? You think they're gonna want to do all this? No. So whether or not they go for it depends upon what those animals are used for. And what if it was a racehorse? You think they're going to keep it around? No. They're probably going to euthanize that type of thing. Okay? All right, so that is as far as the horse is concerned. Again, let's look at the clinical signs, laboratory findings, diagnostic test, treatment, and prognosis of adrenal-dependent hyperadrenocorticism. We've been talking about pituitary, right? And which one's more common, pituitary or adrenal? Pituitary is more common in all species. Like I said, I used to think that adrenal was more common in cats because it wouldn't respond to the low-dose dexamethasone suppression test. But they found out because the cat just didn't want to cooperate, just like the horse does. Okay, so they found out that the majority of all our three main species, equine, canine, and feline, are the ones that we talk about, because the bovine, as I said, what usually will happen to a bovine is they get sick and go on feed and stuff. McDonald's, right? And so, they don't usually put all that money as far as that's concerned. Okay? So let's look at the adrenal dependent. Clinical signs, are they going to be much different from pituitary dependent? Because if they basically, what's causing